Welcome to the PN2 Module 9 recording on intracranial regulation. Again, we have our usual slide reminding you that you're responsible for all of the resources that have been provided to you through Rasmussen. And here are our objectives for this particular module. We're going to begin talking about two patients who were involved in a motor vehicle accident. They were brought in by the paramedics. One of the patients is unresponsive and the other has absence of sensation to lower extremities. Take a minute, pause the recording, and jot down what are some potential injuries that these two victims might have incurred. They may have experienced a closed head injury. If that were to happen, cerebral edema could occur, as well as increased intracranial pressure. There could be a spinal cord injury involved, and in addition, some chest or abdominal trauma. And that is just to name a few. Let's take a few minutes to talk about cerebral edema and increased intracranial pressure and talk about what are some of the differences between the two and what are some of the causes. So cerebral edema is actually a life-threatening condition that develops as a result of an inflammatory reaction, and most frequently this is the consequence of some kind of cerebral trauma or massive cerebral infarction, hemorrhages, an abscess, tumor, allergy, sepsis, hypoxia, and other toxic or metabolic factors. At present, when various traumas and traumatic cerebral injuries are frequent because of death in young people. Treatment strategy for cerebral edema is of utmost importance, and monitoring the patient's condition in the intensive care unit is a necessity. Increased intracranial pressure is a rise in the pressure inside the skull, and it can result from or cause brain injury. Increased intracranial pressure can be due to a rise in the pressure of the cerebrospinal fluid, and this is the fluid that surrounds the brain and the spinal cord. Increase in intracranial pressure can also be due to a rise in pressure within the brain itself, and this can be caused by a mass, such as a tumor, bleeding into the brain, or fluid around the brain, or swelling within the brain itself. And an increase in intracranial pressure is a serious medical problem. The pressure can damage the brain or spinal cord by pressing on important brain structures and by restricting blood flow to the brain. Now, there are many conditions that can increase intracranial pressure. Common ones include an aneurysm that has ruptured, or a subarachnoid hemorrhage, a brain tumor, encephalitis, head injury, hydrocephalus, which is increased fluid around the brain, hypertensive brain hemorrhage, intraventricular hemorrhage, meningitis, subdural hematoma, status epilepticus, and stroke. And so some of the clinical manifestations include in early symptoms for adults. We sometimes see headache or change in consciousness. Later we can see some behavior changes. They might develop seizures. There's a change often in neurological symptoms that could include weakness, numbness, eye movement problems, and double vision. Vomiting can occur also. And then for infants, you might witness some irritability, lethargy, poor feeding, and you might actually see the bulge of the fontanelle. And infants also might experience vomiting. Intracranial pressure can be directly measured with an intracranial pressure monitoring device. This would obviously be taken place in an ICU. And there's an important relationship between the blood pressure, the pulse rate, and intracranial pressure. They call that the Cushing's triad. It's not to be confused with the Cushing reflex. The Cushing triad is a sign of increased intracranial pressure, and what you will see is hypertension. So there's progressively increasing systolic blood pressure going up. You may notice bradycardia, and then a widening pulse pressure. Now the pulse pressure is an increase in the difference between the systolic and the diastolic pressure over time. So to find that pulse pressure, you take the systolic minus the diastolic and then document that. And following those trends, if you see that there's an increase over time, and you see along with it an increase in blood pressure as well as decreased pulse, it suggests that there may be a cerebral hemorrhage in the setting of a trauma or a space-occupying lesion such as a brain tumor that's growing and a possible impending fatal herniation of the brain. And just as a little FYI, Cushing's triad is named after an American neurosurgeon, Harvey Williams Cushing. Care of the patient who has an increase in intracranial pressure focuses on lowering that, and one of the ways that we do that is through positioning, and that head should be tilted at 30 degrees in order to optimize the cerebral perfusion pressure and control of the increase in the intracranial pressure. Now that doesn't mean we push the head forward. They should be sitting or lying in the bed at an angle of 30 degrees to optimize that. We often see hyperventilation applied. In addition, controlled hypothermia decreases the rate of the metabolism in the brain. So they have cooling blankets and other measures to initiate the hypothermia that's needed to prevent brain injury. We're going to be looking for a slightly positive fluid balance maintained using crystalloid or colloid solutions, so hypertonic, hyperoncotic solutions, at the same time maintaining the cerebral perfusion pressure exceeding 70 millimeters of mercury. The treatment includes administration of antihypertensive meds, NSAIDs, and barbiturates. So the steroids decrease the permeability of the capillaries and the hematoencephalic barrier, sorry, that was a mouthful, promoting the movement of sodium and potassium ions in water through the main endothelial membrane, and thereby they're used in the treatment of the vasogenic cerebral edema as well as edema caused by a cerebral tumor. Decadron or dexamethasone should be administered slowly, and I had a student who looked that up recently, and one of the side effects that was listed was perineal irritation. And so essentially what happens if you push that too quickly, your patient will feel as if their groin is on fire. So make sure you give it very slowly to avoid causing that discomfort for your patient. Make sure that we're giving stool softeners or laxatives if necessary to prevent any straining during a BM. So the nurse enters the room and discovers the patient having a seizure. Let's take a minute and pause and think about what the clinical manifestations of a seizure would be, how we're going to manage that, and then we'll discuss a little bit about status epilepticus. So to start with, no seizure types and symptoms. So a grand mal seizure or generalized tonic-clonic, your patient would be unconscious, they would be experiencing convulsions and muscle rigidity. An absent seizure, they may experience a brief loss of consciousness, but you don't see the tonic-clonic movements that you would in a grand mal or generalized tonic-clonic. Myoclonic, sporadic, you might observe isolated sporadic jerking movements. Clonic is repetitive jerking movements. Tonic is muscle stiffness and rigidity, and atonic is loss of muscle tone. So management of the seizure is going to include oxygen if the patient needs it. We want to have suction equipment nearby, so if your patient is on seizure precautions, make sure everything you need for suction is there. Have airway supplies in case we have a loss of airway. Make sure we have IV access. We often give IV medications to help manage, especially a long-term seizure. Side rails up and padded. However, just take note that is not currently evidence-based practice. So know your facility's policy. Some facilities are still using padded side rails and having them up for patients who are on seizure precautions. Others are not, but always we want that bed in the lowest position possible. So depending on the type of seizure, There may be additional interventions to have in place. Always observation and documentation of the seizure that's witnessed. Patient safety is utmost importance, so you want to lower that patient to a safe area. If they're in bed, you obviously keep them in bed, but if they're sitting up, you want to lower them down, make sure their head is protected, and then placing them in that side-lying position is very important, especially post-dictal, to reduce the risk of aspiration. We don't restrain patients who are having seizures anymore, and we never force anything into the patient's mouth. So let's talk a little bit about status epilepticus. This is a prolonged seizure that lasts more than 5 minutes or repeated seizures over the course of 30 minutes. And this is considered a medical emergency. We're not just going to watch this. Call that rapid response and get your team there to help support you with this. We want to make sure we have an established airway. They may grab some ABGs. Most likely they're going to give some lorazepam or diazepam to this patient. They may consider doing rectal diazepam if we don't have IV access. And then often there's a loading dose of IV phenytoin, which is Dilantin. And then they'll do a maintenance dose from there. There are patients who are at risk for new onset of seizures. These include patients who've had a stroke, patients going through alcohol withdrawal, anyone who's had a head injury or a high fever, any signs of increased intracranial pressure, and if they have a diagnosis of meningitis or encephalitis, they're going to have increased risk for having a seizure occur. I want to spend a few minutes to talk about some medications that are used for acute seizure management. And the medication that they're going to use depends on the type of seizure that the patient has. Medications for the tonic-clonic seizure activity can include Ativan or lorazepam, and this is a short-acting medication for acute seizures. Diazepam or Valium works a little longer, but is also often given for acute seizures. Dilantin, it takes time to build up in the system, and so as I mentioned in the previous slide, we give a loading dose of IV and then regular IV doses, and then we'll transition to oral. And the levels, Dilantin levels, should be monitored regularly. Normal Dilantin levels are 10 to 20 micrograms per milliliter. And some patient teaching that you should provide for patients with Dilantin is to provide frequent oral hygiene. This can often lead, this medication can cause gingival hyperplasia, and people should not take Dilantin and warfarin and be on warfarin as well. So just keep those in mind. Evaluate most current blood level of the medication if appropriate. So did this patient drop below therapeutic levels, and did they have a breakthrough seizure? Always be aware of any drug-to-drug or drug-to-food interactions, and as I mentioned, maintain that therapeutic blood levels for maximum effectiveness. And we need to be sure to document and report any side effects or any adverse effects that happen. Another fairly new, it's not super new, it's been around for a bit, medication that we are using to treat seizures is Keppra, which is levetiracetam. And if you just look up Keppra, you'll find the spelling. It's a big word. And this medication also requires therapeutic levels, and that is 12 to 46 micrograms per milliliter for that medication. We're going to move on to our second patient who was involved in that motor vehicle accident, and this patient's awake and reports lack of sensation below the umbilicus. So think about what injury you might suspect this patient incurred. If you said spinal cord injury, you're correct. Note that paralysis occurs below the level of injury with a spinal cord. Injuries that are C4 and above, we're going to notice paralysis of respiratory muscles and all four extremities, and we classify this as quadriplegia. The higher the injury, the greater the loss of function. And there's often trouble regulating the temperature below the level of injury as well. It shows a swimming pool here and car accidents as very common causes of spinal cord injuries. This slide is a great resource. I'm actually going to print this out and give you a copy of it in class, so don't feel like you have to print it out in big where you can see it. We're going to have an activity that's designed around this particular slide. But I just want to draw attention to a couple things. The high cervical injuries above C3 well, C4 is what the previous slide talked about, but they'll result in loss of respiratory function and death unless ventilator support is immediately provided. So there's some terms related to spinal cord injuries that it's good to be familiar with them and what the difference is. One of those is tetraplegia, and this is the same as quadriplegia. So the tetra also means 4. So the individual loses loss of the arms and the legs. The quadriplegia, again, paralysis of all 4 extremities. In comparison, quadriparesis is a weakness of all 4 extremities. So maybe they still have some sensation, but the injury caused a weakness. Paraplegia is paralysis of lower extremities, and then the paraparesis is weakness in the lower extremities. I'm not going to spend a lot of time on reading this to you. Do look over it, and it will help you when we do our activity in class. There's no way to reverse damage to the spinal cord, but researchers are continually working on new treatments, including prosthesis and medications that can promote nerve cell regeneration or improve the function of nerves that remain after a spinal cord injury. And this includes things, there's a lot of new work being done on stem cells and seeing some individuals having results with that. But in the meantime, our spinal cord injury treatment is going to focus on preventing further injury and then empowering people with the spinal cord injuries to return to active and productive lives. Early treatment of the spinal cord trauma with large doses of methylprednisolone or Solumedrol have been shown to be extremely effective in the prevention of spinal cord damage after the trauma occurs, if it's administered within 8 hours of the injury. So providing this medication after 8 hours following the injury is less effective in the prevention of the damage after the traumatic event. It appears to work by reducing the damage to nerve cells and decreasing inflammation near the site of the injury. However, it's not a cure for the spinal cord injury. H2 receptor blockers may also be administered. An example would be ranitidine or Zantac. So for our patient who's had this situation, we're going to immobilize the patient. They may need traction to stabilize their spine, to bring the spine into proper alignment, or both. And in some cases, a rigid neck collar may work. Often a special bed may be ordered to help immobilize their body. Often surgery is necessary to remove fragments of bone or foreign objects, herniated discs, or fractured vertebrae that appear to be compressing the spine, and surgery may also be needed to stabilize the spine to prevent future pain or deformity. Once the patient is through this acute stage, they will be looking at rehabilitation, focusing on maintenance and strengthening of the existing muscles and their function, and redeveloping fine motor skills and learning various adaptive techniques to accomplish ADLs. Care of the patient with a spinal cord injury includes management of airway and breathing. So again, we're back to our ABCs, making sure a person can breathe before we worry about other things. Urinary elimination. They often do not have the ability to avoid on their own, and so teaching them to self-cath if they have use of their hands, or if not, working with them. Sometimes they do urostomies for these individuals. Sometimes they have caregivers who help with keeping that bladder empty. Nutritional management is very important. These individuals need very sound nutrition, but not too many calories. Patients who have spinal cord injuries and who are overweight have a lower quality of life because it's harder for them to get themselves around, and they become less mobile the more weight that they gain. So good nutrition, but weight management. And so we often have to advocate for early dietary consults. For a while, enteral feedings may be needed, depending on where the spinal cord injury occurred along the spine. There could be problems with chewing and swallowing that could be compromised. There will be lots of patient education and family education and caregiver education that will be involved, focusing on all levels of health promotion and all aspects of care. Rehab, mentioned that already. And then we want to return this patient to optimal functioning. You know, it may not be realistic that they can engage in all the activities that they did in the past, but you would be amazed at the great quality of life that people with spinal cord injuries can have when they're empowered and they believe in themselves and have the support of their family and can get through all the emotional part of the trauma that occurs. A potentially life-threatening condition that can occur with patients who have spinal cord injuries is a condition called autonomic dysreflexia, or AD, and this is caused by GI or genital urinary or vascular stimulation. You can see a full list of key features of autonomic dysreflexia by going to chart 43-2 and then chart 43-3. There's information for emergency care, but we're going to spend a few minutes talking about this. What you would see with autonomic dysreflexia is a sudden increase in systolic and diastolic blood pressure and the bradycardia. You also will see a flushing of the skin above the level of the lesion. So wherever that spinal cord injury occurred, you'll see flushing above it with pale skin below it. The patient might also experience blurred vision. They could have a severe throbbing headache and experience feelings of apprehension. Now, this is an emergency situation. The very first thing that you do, the top priority, is to place your patient in a sitting position or as close to sitting as you can get them in, and then call a rapid response. From there, we're going to start to troubleshoot to find out what is actually causing this. And the most common cause of it is an overextended bladder. So we're going to assess for the treatment of urinary retention or a UTI. If their bladder is full, we obviously want to empty the bladder for them. If that's not the case, then we're going to look for a fecal impaction to see if they haven't had, when was the last time they had a bowel movement? Is that stimulating this? And then we're also going to assess the skin for any signs of any pressure injury symptoms. And then relieve those as soon as we can. We want to monitor the blood pressure every 10 to 15 minutes. And we're going to administer nifedipine or a nitrate to lower the blood pressure as needed. If it's recurrent, so some patients actually have this happen. It's not just like a one-time freak thing that happened, but they have regular occurrences of it. They may be prescribed an alpha blocker prophylactically to prevent this from happening. It's a very uncomfortable experience for the patient when this autonomic dysreflexia occurs. Moving away from our first two patients who came through our ED, we're going to talk about a patient who is diagnosed with Parkinson's disease. Pause a moment and describe this disorder and its clinical manifestations. Parkinson's disease is a progressive neurodegenerative disorder. There are 4 cardinal signs, so you might see a tremor or will see a tremor, muscle rigidity, bradykinesia, so slow movement, and postural instability. If we back up a little to the muscle rigidity, know the difference between cogwheel, plastic, and lead pipe. So cogwheel wheel is manifested by a rhythmic interruption of muscle movement. Plastic, in comparison, is a mildly restrictive movement, and then the lead pipe is total resistance to movement. So they might experience one of those 3 things. You'll also note that there's this flat affect of the facial expression. I'll have a picture on the next slide for you to see what that looks like. They kind of look like they have a mask on, and they don't. Even I had a very close family friend who lived with us for probably 20 years. He honestly just died in the last year, and he would be laughing, and he would be super happy and laughing, and you could tell every part about him except his face. His face was this flat affect, this mask. These individuals often experience emotional changes as well. So maybe they were stoic at one point and now all of a sudden they're very sentimental and teary. And then these people with Parkinson's also will experience some bowel and bladder changes as well. This disease is separated into stages. Stage 1 is mild, and it progresses to stage 5, which is a completely dependent position for individuals. This slide shows the mask-like expression that's typical of patients with Parkinson's disease. Treatment for Parkinson's disease often focuses on promoting mobility, so we want to continue with exercise programs, keep them moving. It'll include some physical therapy along with that. With drug therapy, carbidopa, levodopa, the brand or trade name for that is Sinemet. That's a very common medication, and the timing of it is very important. The medication has a fairly short half-life, and so timing it for when the individual needs the most mobility for the activities of daily living is very, very important. There are situations where they use surgical management. There's stereotactic pallidotomy is what it's called. You can find this in the textbook. You don't actually have to memorize any of these words here, but they can do that. And then there's deep brain stimulation, where they put these electrodes in the brain and they have this device similar to like a pacemaker that's embedded and sends these regular impulses to the brain that seems to provide the individual some increased control over their muscle movement. The next disease process that I want to talk about is multiple sclerosis, or MS. So pause a moment and jot down just different things that you know about this disease process. This also is a degenerative disease, but this attacks the central nervous system, and it's an autoimmune disease process that attacks the myelin, which is it's those fatty tissues that go around the nerve fibers in the brain and in the spinal cord, and then it prevents that normal transmission of nerve impulses, and so patients will have various effects from it. They may have motor control issues, balance issues, vision problems, memory can be affected as well. And there are multiple types. We'll talk about some of them on the next slide. The relapsing remitting type of MS often is shorter in duration, days to months, and patients can remain symptom-free for months or years. I worked with a nurse who actually had this. I came into work one day and she was my patient, and she was not able to get up and walk at that point. And then the next week when I worked, she was working alongside me. It was really quite remarkable. She would come in and they would give her a treatment at that point, and this was easily 15 years ago, and the treatments that are available now are way more advanced, but at that point she was just getting high dose IV steroids, and so we'd load her up with those and it would put her back in remission, and in a very short time she'd be back to her full life. Another type is secondary progressive. Most of those who are diagnosed with this will eventually transition to a different type, or I should say those who were diagnosed with the relapsing remitting will eventually transition to the secondary progressive. And this is a slow, steady progression with or without relapses. And the relapses do not fully remit. And I actually have another friend, I've got quite a few friends, sadly, who have MS, but this other friend, I have been providing medical care to her, nursing care to her for over 15 years. And I've watched her go from when I started just giving her B12 injections once a week. We would meet at church and we'd go to a private place and I'd give her injection. And then she progressed to needing a Foley catheter. And then now she actually has a suprapubic catheter, and I would go into her home and change her Foley catheter, and now I go about every 3 weeks and change it. but it was interesting watching her over 15 years. When I first met her, she was able to walk with a walker, and she got around pretty well. And then she progressed to not being able to balance well and to be safe even in a walker. So now she's in a wheelchair, and up until about a year ago, she still had some pretty good fine motor control. But I've noticed in the last year she's losing that fine motor control. So she has a little less control over her scooter, her wheelchair. She has a little control knob that she drives her electric wheelchair with it. And even things, Alexa has now become her friend, because even turning lights on and changing volumes, and it's been very, very hard for her. So, but that's the type that this particular friend had. It was just a very steady, slow progression. Occasionally she'd have a flare, but rarely did she go back to a full remission with it. There's primary progressive. This is steady worsening from the start, and they don't have periods of relapses and remissions. And then the progressive relapsing. This is steadily worsening from the onset. There are flare-ups with or without are also present. So as you can see, the percent of people affected by each of them. And don't spend time memorizing these 4 types. Just be aware that they exist, and that MS looks different for every person who is diagnosed with it. So don't expect the same symptoms to present for each person, but don't worry about memorizing these different types. Moving on to our next disease process, we have a patient who presents with lower extremity weakness that is progressing to paralysis and upper extremity weakness. Which disease process is suspected? So we're going to talk about Guillain-Barré syndrome, and this is often associated with bacterial or viral infections. And in countries where the recent Zika virus has emerged, the number of Guillain-Barré cases has increased, suggesting that the Zika infection can also trigger Guillain-Barré. There are also reports of some vaccine increasing the risk for Guillain-Barré slightly, but the evidence for that is weak from the CDC. The CDC reported that, and it's believed that the precipitating infection or event sensitizes the T cells to the patient's myelin, resulting in the production of a demyelinating autoantibody. I would like you to look at chart 44-1 for key features. As the syndrome progresses, respiratory ability may be impacted, and this can lead to respiratory infections or even respiratory arrest. Your patient may need to be intubated until symptoms subside, and the respiratory arrest is often the leading cause of death. What we usually see is this initial muscle weakness and pain that leads to ascending paralysis. So we see paralysis in the lower legs, and then the full legs up to the point where the diaphragm can be affected and they may not be able to breathe. So this is an autonomic dysfunction. A patient may also experience double vision with that as well. Care of the patient with Guillain-Barré focuses on preventing respiratory and/or cardiac distress. They may attempt plasmapheresis. This is where they remove the circulating antibodies, assuming to be causing this disease, and then the plasma usually replaces itself, or the patient may be transfused with albumin. We would want to be working on improving mobility and preventing complications and PT and OT. These individuals will need fairly long-term rehab once they're through the crisis stage and they regain the sensation and the mobility, but they almost have to learn to walk all over again. Moving on to our next disease process, we're going to talk about a patient who's admitted with an exacerbation of myasthenia gravis. Think about what clinical manifestations you'd expect to find on assessment, and go ahead and pause this and reflect on that, and then restart it when you're ready. So I will refer you to chart 44.3 for some key features. What we see is there are several manifestations of this. One is motor related that affects mobility. So we see a progressive or proximal muscle weakness that worsens with repetitive use and usually improves with rest. So it's not ascending like your Guillain-Barré, but the more they exercise or have activity, the weaker they get. And then when they rest, they get better. We often see poor posture because those muscles, even those core muscles, get tight or get tired very quickly. We see ocular palsies, ptosis, so maybe an incomplete eyelid closure, diplopia, respiratory compromise can occur, as well as loss of bowel and bladder control. And the patient has a generalized fatigue that they just live with all the time. There are sensory perception manifestations such as muscle achiness and paresthesias, and a decreased sense of smell and taste as well. You might find this slide helpful for you. We do know that this is most common in adult women under 40 and then older men over 60, but it can occur at any age. Additional or concurrent lists of some of the clinical manifestations, in addition to what we talked about on the previous slide, could be the dropping of one or both eyelids, altered speaking, limited facial expressions, a weakness in the neck, arms, and legs, and then we did mention the double vision, which improves or resolves when one eye is closed. There are two types, ocular and generalized, and it can take many forms, just like the MS can take many forms, from mild disturbances to rapidly developing generalized weakness that can lead to death from respiratory failure. So it's they do suggest that there's a slightly higher incidence of this among men, and it is a progressive disease. So if they have flares, it can continue to get worse every time they do. Treatment for myasthenia gravis includes cholinesterase inhibitors. Drug of choice is pyridostigmine, and I'm going to spell that for you, PYRIDOSTIGMINE. So that's the generic name. There are potential adverse effects to this, which includes a cholinergic crisis. What we see with that is a sudden increase in weakness, and it's accompanied by hypersalivation, sweating, and increased bronchial secretions. It can often be difficult to know the difference between a myasthenic and a cholinergic crisis. So if you go to table 44.1, you'd be able to see a comparison between the two there. We also put patients on chronic immunosuppressant agents such as methotrexate or Rituxan, Rituxan. That's one of those monoclonal antibody medications. And we also may prescribe rapid immunotherapy agents. What's really important that we provide respiratory support for them, encouraging them to cough and deep breathe. We may need to do suctioning or chest physiotherapy, take advantage of postural drainage, percussion, and vibration to mobilize secretions. Patients are going to tire very easily, so we need to make sure we're providing assistance as needed to allow them to rest. They can rehab when this crisis passes, but the more we work them and harder we work them, the more it's going to exacerbate this. They might also consider a thymectomy. I didn't mention that as we were going down through the list as well. And this is the end of our Module 9 presentation. I'll see you in class.